Hello again, everyone, and welcome to another edition of the Inside Lowell Daily Pulse, the Thursday, November 13th edition of the Daily Pulse. I'm your host, Teddy Panos, coming to you from the WellPoint Studios here in downtown Lowell. On today, we're going to have a little discussion about, well, public health. A lot of topics have been in the news lately here in Lowell, and quite frankly, throughout the Commonwealth of Massachusetts, throughout the United States of America, and the world for that matter. And when we want to talk public health, well, who better to talk to than the City of Lowell's Director of Health and Human Services, Lisa Golden, who is joining us here in studios today. How are you, Lisa?
I'm great. Thank you so much for having me.
You say that now. Let's see if you say it when we're all done.
Yes,
right?
yes. No, this will be a great conversation. I will be happy when I leave. Thank you.
Well, there's a lot of information that we want to get out there. I know you had reached out to me when we were having the discussion. Well, it was really kind of hot about a month ago before the elections kicked it off the front burner, but harm reduction, safe injection, what some people say, and you kind of want to set the record straight on a couple of things,
yes,
which we're looking forward to doing today. And there's a bunch of other stuff we want to talk about. Health has been a big issue over the last year in Lowell. The banning of kratom, if I'm pronouncing it correctly, the banning of rodenticides, the lack of staffing of public health nurses, and so much more. Plus, we will not forget, you have to remind me, we want to tell people, well, we're in the midst of flu season now, so we're going to give them a little public health advice as well, okay?
Correct.
And it'll come from a professional, not from me.
Yes.
All right.
But you can have your say as well.
Oh, I most certainly will. I've been waiting for this one. I'm passionate about at least the harm reduction discussion. So we're going to get to all of it with Lisa in just a couple of minutes. First, let me thank my Daily Pulse sponsors. You know about Ray Booten, right? Licensed realtor in Massachusetts and New Hampshire, certified appraiser in both states as well. So if you're looking to buy or sell a home, a business, or a commercial property, find Ray today. And the good news is he is easy enough to find online at realestaterayBooten.com. That's realestaterayBooten.com. By the way, look onto our Inside Lowell Facebook page a little bit later on today. Ray has a brand new listing. Heck of an investment property, multifamily property, 4-family in Methuen. It's near a park to boot. Can't beat it. Look on InsideLowell.com's Facebook page for more details on that, and then contact Real Estate Ray Booten. Thank you as well to our friends at WellPoint for hosting us here in the WellPoint Studios. It's the only health plan offering healthcare benefits exclusively to Massachusetts GIC members. At WellPoint, your whole health is their whole point. Thank you to WellPoint. Thank you to Ray. Some other sponsors, we'll thank them in a little bit, but since we left off talking about a sponsor with health, let's talk health with Lisa Golden, the City of Lowell's Director of Health and Human Services. All right, so a couple of months ago, it came out that one of our state reps here in Lowell, Tara Hong, had co-signed a bill about harm reduction, and as part of the language in that bill making its way through the legislature here in Massachusetts, what are commonly called safe injection sites is part of it. It blew up on the Lowell City Council floor with a motion to create an ordinance banning them. Which have they come forward with said ordinance yet?
So the public hearing will be on the 18th, which is next Tuesday.
Next Tuesday.
Yes.
Okay, so it could be a fun public hearing. Great timing on this podcast then. So you reached out. You said, I got to set some things straight. There's some things being said about safe injection sites, on needle exchange, et cetera, that you want to set straight.
Correct.
So here you go.
So this bill is for overdose prevention centers. So that's what the bill is, overdose prevention centers. And this is not the first time this bill came up. This is actually year number 8. So this bill 8 years ago was put in so that there would be 2 pilot sites in the state of Massachusetts, and they would be funded by the state of Massachusetts. The problem is that we've gotten 8 years into this, and the bill has gone nowhere. So who knows whether this will go anywhere, will not go anywhere, and the reason for the overdose prevention centers is not so that people would just walk in, shoot up, and leave. It's so that there would be wraparound services to try to get people off of drugs. So their drugs would be tested, make sure the drugs would be safe. They would get mental health services. They would get other services while they were there, that there would be a medical professional there while they're using drugs. And then ultimately the goal would be so that they would get off of drugs. And that is the ultimate goal for any street worker, any clinical recovery specialist, and any person who's working with this substance use, people on the streets who are using drugs. And this is what the bill is. And this is, like I said, not the first time the bill is happening. There is one of these in Rhode Island, and the bill actually passed a little over 3 years ago, and it took 3 years for one center to get up and running, for the funding, for it to be put into a place, and to get people to actually run it. So it's not like this is going to get up and going anytime soon. But this is why this happened. And the reason that I reached out to you, Teddy, was that when you had some of the candidates in and you asked about this, in one of the group of candidates, one of them answered the question about overdose prevention centers, and one of them answered the question about needle exchange, which is actually syringe service programs. So two of them answered the question differently related to two different programs.
Okay. You use specific language. You call, instead of harm reduction centers, safe injection sites, the language that critics will, well, harm reduction centers is one that proponents generally use, but critics will say shooting galleries, safe injection sites, whatever. You're using opioid overdose prevention centers. Yeah. I know language is important. Right. Can I
just go back to harm reduction?
Sure.
So harm reduction is also wearing your seatbelt, smoking a filtered cigarette, putting on sunscreen, and things like that. So when you say harm reduction, you really can't say harm reduction related to any of this, because also Narcan is harm reduction. There's a whole bunch of things related to harm reduction. So you can't say harm reduction or getting rid of harm reduction. So you do have to call them by their specific terms. So you can't, so if the city council said, like, we want to ban harm reduction, that means that we're not wearing our seatbelts, we're not stopping at a red light, we're not doing anything related to any harm. So we can't necessarily, that's why we use our specific terms related to them.
And there are also things with stigma, you know, where vilifying people who are addicted and in recovery. And you know, we went through this for a long time, you know, with the Megan House Foundation, which I've been, you know, helping for over a decade now. You know, instead of sober homes, we'd call our place success homes. Again, it's all about changing the stigma, but in reality, in whatever you call it, it's kind of the same thing, right? You're talking about the same issues. Needle in the case of overdose, we're talking, when they say harm reduction, they're talking about needle exchange programs. We're talking about place supervised sites where people can use drugs, drugs they've purchased. So I do want to clarify that before we get into the pros and cons of this discussion. So as you understand it, the way the bill is proposed in Massachusetts, the way it's been implemented in Rhode Island and in many other parts of the world, most famously in Vancouver, British Columbia, which I want to talk about. The point, folks come to a facility operated by who?
Well, that depends on who wants to open it. So most places it's by a nonprofit or church group. So in New York, they're run by church groups, but they're not funded by the state. So they don't work very well.
Okay. In Vancouver, British Columbia, it's the state, the county that funds it. Okay. Yep. You mentioned people can bring in drugs. Correct. Now, they're drugs that they purchase illegally somewhere else. Yep. You do not sell them at these sites. So they are not sold at these sites. You said that the drugs are tested. Yep. Obviously, you're testing for fentanyl and other more harmful items that are in there, correct? Yes. All right. Is the testing mandatory? If somebody goes to a harm reduction center with drugs and you say, well, we're going to test them or else we're not going to let you inject them in our site, is that part of the legislation? And this is the thing. That would be part of the bill. And I believe we're putting the cart before the horse because we don't know what the bill says. And I would believe that would come out from the state, and I believe that would be part of it. I have read the quick text that they have online, whatever you can find publicly, and it doesn't say. It's very general, which is another cause of concern. Okay, in terms of the people who come there, drugs get tested. They inject by themselves, or is one of the supervisors there. Do they help them inject?
So the way that I have seen the setup, because I've seen pictures of the setup in Rhode Island, it's as if you went to have your blood drawn from the phlebotomist, but it's backwards. So it appears to me as if when you go to have your blood drawn, the phlebotomist, you sit backwards and there's two walls and you're sitting this way. So it would appear to me that the person shoots up themselves and the needle box is sitting backwards. So I don't think, and the chair is sitting backwards. So I would assume the person's shot up for themselves.
Okay.
Yeah.
And which I believe is important from legal
Correct.
standpoints, because whoever's running it, and if in any way, shape, or form a municipality or
Correct.
state government is involved, you've got some problems there. The effort to provide recovery services, mental health services, whatever, maybe any kind of counseling, does that happen before or after somebody ingests the drugs? The drugs.
I would assume it would happen before and after. So I would assume it would happen before, after, or someone could just come into the site and get help without doing drugs.
Okay. And that side, that help is available there. There are trained professionals. Yeah. When we say trained professionals, what are we talking about? Are we talking about a combination of medical professionals, like a nurse who knows life-saving measures if something goes horribly wrong? People who are certified, licensed in recovery and addiction services, etc.
Yeah, like the co-op has clinical recovery specialists, and then there's certain licenses that you can get, like LDAC and things like that. Like there's certain things that you can get to work with people in recovery, like if you're in a recovery center. So certain things that you can get, or a licensed social worker, things like that. And I believe when you see the text for the bill, there's exemptions to certain laws. So I believe that the exemptions for those laws would be like if you're a nurse or a paramedic, that exempts you to be able to be in a place where people are using drugs. But I haven't looked into the bills, to be honest with you.
Okay. Yep. Is there a problem? Actually, let me first ask, what's your official position? If the city council and the city manager were to call you in front of them, which my hunch is they're going to do next Tuesday night, what would your recommendation be? Have you already provided it, or are you keeping us all in suspense till Tuesday night?
I'm keeping you all into suspense.
Okay.
Until the bill comes and passes in front of them, I'm probably not going to form an opinion.
The bill being the ordinance that the city solicitor and the city draw up to vote on, or are you talking about not until it passes the state legislature?
The state legislature.
Okay.
Because I'd like to see what it actually says.
Right. So that indicates to me that depending on the language of it, you might support certain components of it.
Correct.
Okay.
I'd like to see what it actually says. And I'd also like to see who's going to fund it. Because I don't think that the way that, like the money that we have within the city, I don't think we have money to support it. I don't think we have any place actually to put it either. So I'd also like to see if some other there are cities and towns that when there were going to be 2 pilot programs, there were some cities and towns that would do those 2 pilot programs. So I kind of like the way it was before. And if those 2 cities and towns did it, I'd like to see what they would do with it. And then we could see what would happen with it that way.
So you'd rather Lowell not be one of the guinea pigs, somebody else be, and then we can see if we can perfect it or say, this is a non-starter.
Correct.
Okay. Why are you open to the position? First of all, a little bit about your background, so folks know that we're talking. How long have you been in public health, in nursing, etc.?
So last year was my 4-year anniversary in this job. Just in time
for COVID.
I came in when I came in when there was a lull in COVID. I thought COVID was over. Hence the reason.
Little did you know.
Hence the reason I came into the job. But then it reared its ugly head again. So that was when I came into the job. I've been a registered nurse, I think, for 36 years. Most of my career was in the hospital setting. I've done mostly adult ICU nursing supervisor, which is managing the hospital. I've done some pediatrics. I've done some recovery room. I do currently work in a hospital as well in my spare time when I'm not doing this job. So,
in other words, the city manager isn't paying you enough.
Well, I like to keep my skills up. So, in this job right now, I oversee the veterans council on aging, library, and the health department. In the health department, we do public health, which is overseeing 90 infectious diseases, tobacco control, substance abuse, which is the co-op, which we hear a lot about, and then burial permits and homelessness. So we do a lot with the nonprofits for homelessness, and the co-op goes out for any non-fatal overdose and follows up with anybody who has overdosed in the last 24, 48, or 72 hours to put people into treatment if they want to be in treatment. We also will try to get services for anybody who's in an encampment or who's homeless, who comes to the health department. We have a social worker, we have the director of homelessness, and then there are 11 people on the co-op team who go out in the 2 vehicles daily to the church, to LTLC, the shelter, or we'll just go out on the street to see if people need any help.
Okay, so I wanted to establish that because you're not a podcaster or a talk show host. Nope. You're not a politician. You're not, these Facebook warriors who are public health experts or whatever. You actually have dedicated your career 3+ decades into public health, nursing, etc., and all facets of it. When we say public health, in this particular case, we're talking about drugs, addiction, overdose prevention, etc. But that changed, right? For 4 years, for a couple of years, your job was ruled by COVID and flu/influenza outbreaks. There was a time early, back in about 2014, 2015, when once again overdose and opioid deaths kind of became like the main thing, but also mental health is a major component of what you folks are involved with, and homelessness as well.
Mm-hmm. Yep.
All right. Yep. So you are an expert, we can say, in this field. Yep. All right. So I want to get into the weeds on some of this stuff with you. All right. You ready?
Sounds good. Let's go.
Well, I'm going to make everybody wait, because this is a good time for a commercial break. I want to thank all my Daily Pulse sponsors one more time. Ray Booten, licensed realtor in Mass and New Hampshire, certified appraiser in both states as well. If you are looking to buy or sell a home, a business, or a commercial property, find Real Estate Ray Booten today online at realestaterayBooten.com. Thanks as well to our friends at WellPoint. At WellPoint, your whole health is their whole point. Washington Savings Bank, banking that goes the extra mile. Make the switch now to Washington Savings Bank. TMI Properties, TMI Cares, developing and managing their own properties for over 30 years. Experience the quality, the care, and the value of making TMI the choice for your home. Mahoney Oil, providing warmth and protection to generations of families throughout Greater Lowell and Southern New Hampshire for over a century. Yeah, that's right, since 1925. The Greater Lowell Community Foundation, improving the quality of life in our communities through strategic, impactful philanthropy. And by Francis C. Prevention Insurance, the agency Greater Lowell is counted on to protect its most valuable assets since 1982. Thank you to all of our Daily Pulse sponsors and all of our podcast sponsors. We continue our discussion with the City of Lowell's Director of Health and Human Services, Lisa Golden. I do want to also put something out, because you said you might be in support of this depending on the language of overdose prevention centers and the legislation winding its way through Beacon Hill, if it gets through this time. The city's Board of Health director, she's a chairperson of the Board of Health, Joanne Keegan, texted me. I found the date way back on Sunday, November 2nd, when this was a hot button issue and she realized we were going to have you on. Joanne writes, Teddy, I miss sparring with you, with a silly face on there. I know you hated when I was on the radio, Joanne, but we had some good conversations. She wanted me to say this medical professional is not in favor of harm reduction centers, aka shooting galleries, for a variety of reasons, but in part because Narcan is readily available outside of these centers to anyone using. On another note, I do believe Lowell should have clean needles available to prevent the spread of disease to the non-using population. Those getting clean needles return dirty needles in exchange and are brought into the system for testing and treatment. Needle exchange in Lowell connected nearly 100,000 needles between July 1st of 2024 and August 31st of 2025, a 13-month period. Also helped identify hepatitis C cases and HIV and got people into treatment. In addition, disease prevention, it serves as a point of Narcan distribution. She says, and before you go there, yes, they give out more clean needles than collect dirty needles, but there are thousands of fewer dirty needles in our community because of it. And that's from Joanne Keegan, the chairperson of the Lowell Board of Health. Now, she's just one vote on the Board of Health. I don't know if she speaks for the entire board. If it ends up that this becomes a thing and you are somewhat in opposition to the Board of Health, how does that kind of play out?
It's their vote.
It's their vote. Okay.
It's their vote.
You can just make a recommendation?
No. I give them the pros and cons, and they vote. I'm not a voting member. Same thing with COVID, with mask mandates or what happens. I give them the pros, I give them the cons, and then when the people call the health department during the day, they go up one side of me, down the other, and I just let them know, and I protect the board.
Okay.
That's it.
You take the bullets for them.
I take the bullets. I'm the middleman.
Which you did very well in 2020 and 2021 when a certain radio host was having some fun with them.
So, and the same thing with Kratom. The same thing with Kratom when the city council and the Board of Health banned Kratom. I get all the information. I give it to them. And other people gave other information as well. I give them the information, and they vote as they want. They're an independent body that was appointed by the city manager and the city council, and they vote. I'm not a voting member. I'm the middleman.
Okay.
So I'm giving them the information that they need.
So ultimately, it would be their vote, and then the city council,
and the city council, or however this comes out, it will say who gets to do the vote.
Right. So there may not be a local option, as we saw with ADUs and such. So it may get forced down people's throats.
The syringe service programs, it was a vote by the Board of Health to allow them to come in. So the Board of Health were the ones who voted.
Okay. Correct. So since we talked about that, the syringe services, needle exchange or whatever, is the policy that for every one you bring back used, you can get 10 clean needles?
Correct.
Yes. Isn't that insane? Isn't that counterproductive?
So if anybody is a diabetic, they'll know that they come in a package of 10. And that's what it is. They come in a package of 10. So you can't rip the package open.
Okay.
So that's why. And
there's nobody that's manufacturing them in packages of one for this specific reason? That's a pretty good business to get into if somebody wants an idea.
So in the hospital, we rip them open because we go into a patient's room. And we have clean hands, and we go into a patient's room and give one shot. Okay. But if you are a diabetic and you go to the store and you buy them, you're going to be given them as a package of 10. Okay. Because you're a diabetic.
So for health, sterilization reasons, etc., it has to be either a packet of 10 or none.
Correct.
All right.
Correct.
Do you support that policy? Do you think that policy is working?
That is the way that the grant is written. Okay. And that's the way the grant is written, but there's two different ways. So we have the syringe service programs that are wraparound services, and there's a lot involved in them. And we have two programs that have the grant by DPH, they're supported by DPH. And the syringe service programs, the needle exchange is just one part of that. The syringe service programs have the wraparound services, which are mental health. They do testing for STDs. They have testing for hepatitis C and for HIV, and they will also give medications for those. They'll do mental health. They'll do a lot of other things, but you also could go to CVS and Walgreens and buy needles. And then you could buy needles and do your own drugs if you wanted to, and you get none of those other services. And when you also are going to a syringe service program, they'll say to you, are you ready to go to treatment? Would you like to go to treatment? Do you want us to help you get into treatment? Are you ready to get off of drugs? So you're also getting the one-on-one trying to get off. But if I'm going to CVS and buying my needles, you don't get that. You just buy the needles, you go out and do drugs.
And ostensibly CVS is selling them for diabetics, or for people who are injecting legal drugs, right?
No, you can inject. You can say you're buying them for illegal drugs. You can buy them for anything. They're not asking you why.
So, well, but I assume that's how it's marketed, because you had there were some grocery stores or convenience stores that were selling drug paraphernalia but putting a pretty little flower in them, and you guys moved to quickly end that. Right. Is there some thought about trying to work with the pharmacy chains, independent pharmacy, whoever, and say, hey, can we get a handle on this? And
no, there's a law that says that you're allowed to buy buy syringes to inject drugs.
Even if
Yes.
if somebody knows they are illegal drugs.
Correct.
All right.
But also, if you were an outside group, an advocate group, you could go buy a whole bunch of syringes and go out to South Common and be a do-gooder and give them out. And that was when I talked on the council floor. That was what I said. If we got rid of all the syringe service programs, we wouldn't have the wraparound services and people asking, do you want to go into, and they also give out Narcan. Do you want to go into treatment? Do you want to do this? And here's your Narcan and this. These people could just go hand out needles and not take them back either.
And that is by state law.
That is by
So
state
that is
law.
an effort that would have to be
Correct.
filed through the legislature and the governor's office.
Correct.
Okay. You did also take a little exception to there was an implication on the council floor, a discussion. I forget exactly how it went down and who said it, but that it was the Elliott Church, which is one of the facilities, one of the areas where this is becoming an issue next to South Common. That Elliott Church was handing out these needles. From what I understand, they are not, right?
Correct. That's
It's a
correct.
different service that's doing it.
Correct.
But they're doing it on the, I don't want to say the grounds of the church, but in the vicinity of the church. And naturally, since people are getting other services there, food, whatever, shelter, that's where they're ending up.
Correct. So there's different vans, and people are. So there's different vans. There's a van that does. There's a Kraft family van that does services. The care van. So there's a van that has 1 day a week a doctor, a nurse, a wound nurse. We'll do A1C testing. We'll do hepatitis C testing, HIV testing. We'll give out Narcan and do some of the syringe service programs that is in the South Common area and other areas of the city. Then there's a van that gives out needles and does some other syringe service programs, and both of them are in the vicinity of the Elliott Church and the South Common. There is another van that the UMass Lowell has that does goes to the schools as well. So sometimes some of the vans are in different areas and get confused for each other, but two of them are in the area of the Elliott Church. So people get confused on what's what and where they are,
And those are not the vans that are dealing the illegal drugs. to be clear, those are other vehicles that are showing up.
One
areas.
of them is the one that has the needles on it, but it's not. But the needles are not giving out inside of the church.
Okay.
Yes.
All right. So why are you open to this idea? What research, what study, what theory are you relying on to say, you know what, this could work under certain conditions?
Which one could work? Which one are we talking about?
The actual
overdose?
the Overdose Prevention Center, the place where people can come in with their own illegally purchased drugs and inject them in front of professionals.
Right. So one of the first studies that I read said that within 25 miles of it, there were no fatal overdose deaths. So, what we're trying to decrease are fatal overdose deaths. So there's fatal and non-fatal overdose deaths. So there's two different things. So a fatal overdose death obviously is when someone does drugs and dies. Non-fatal overdose deaths is when someone does drugs, needs Narcan, possibly could go to the hospital, possibly could just do Narcan by themselves or with their friends, and it's a near death. So what we track are the fatal overdose deaths, and I believe there was a comment on Facebook on one of your posts last week about the vote for mayor, and someone wrote that the fatal overdose deaths in everywhere are decreased except Lowell. Totally incorrect. Our fatal overdose deaths in 2023 were 50. Opioids were 50. Our total opioid overdose deaths in 24 were 36, I believe, but have gone down. So fatal overdose deaths last year were down by 39%.
Okay. Did you go respond to that person and leave the data on there? Because I love shutting Facebook experts up.
No,
with information and real data.
A city councilor did.
Okay.
I don't I troll Facebook, but I do not comment on anything.
You're trying to stay out of the swamp.
I do.
Okay.
I do. Because a lot of people think they know what they're talking about. The other thing is that on the non-fatal overdoses, Pride Star Trinity, John Kelly has the best tracking device of anybody, and they actually read every report. So in the morning, the police officer on the co-op and our Pride Star EMS read every report. And so we know everybody who's received Narcan in the city of Lowell. Nobody else does that. So our reporting is better than anybody else. I can tell you that on the DA's task force, the Middlesex DA's task force, if I go on one of the calls, they will call me out or they'll call John Kelly out. John Kelly has gone to Washington, D.C. to present, and I believe he went to California to go out because their tracking is better than everybody's.
You come armed with numbers.
We come armed with numbers, and we have better numbers than anybody else. So if it looks like our numbers are higher than anybody else's, it's because our tracking is better than anybody's.
Okay. So what is the state of Lowell's overdose deaths and addiction crisis? So you mentioned the fact that the overdose deaths are going down everywhere across the state except for Lowell is false.
Yeah.
Okay. It was a major, somewhere around 2014 or 2015, your namesake, city manager Tom Golden, no relation, started to sound the alarm on Beacon Hill about the opioid crisis. And what we saw was a period where the crisis, the number of deaths and whatnot started to go down. Then we saw a spike during COVID when all sorts of things kind of shut down and services, things that were working were no longer in play. But it's come back down since then. Where are we compared to 2014 levels when the Commonwealth of Massachusetts and the city of Lowell really started paying attention and started trying to combat overdose deaths?
So the overdose deaths did go up with fentanyl. So when fentanyl first came in, they went up, and now we've dropped back down again with pushing Narcan out. Okay. But we also have in the drug supply is tainted with
stuff that's that's resistant to Narcan now.
Vet narcotics. So that's what it is. And then what's happened is drug dealers have become very smart that they've put some other things in there requiring addicts to use more often, and that's another problem that they need to use more often, and that's requiring them to use more needles. And
they're also lacing drugs that have nothing to do with opiates or fentanyl or whatever with a touch of that. They're trying to create customers for life.
Yeah, they're very good business people.
Yeah,
they're very good business people, and I believe a lot of the drug dealers are chemists, so they're adding other things to the drug supply. So I'm
going to let Chief Greg Hudon talk about that with me. But so if I'm reading you correctly, at least in Lowell, the level of overdose deaths has stayed somewhat steady from 2014 through 2025. We're not seeing a huge spike. We're not seeing a huge decrease.
It went up, and now it's come back down. Correct.
Okay. Yeah. So we're making progress. Okay. Yes. Good. So let's talk about places where overdose prevention centers have been there. You mentioned seeing a study. Most of the studies around the effectiveness of these places center around Vancouver and the province of British Columbia.
Correct.
So some statistics from folks here. The first, now they call them SISs up there, safe injection sites in Vancouver, and they are administered by the province's Board of Health. The first one opened in Canada, opened in Vancouver in 2003. Currently, British Columbia, the province, aka state that Vancouver is located in, has 51 of them. All right. Now, so the National Library of Medicine, which is part of the NIH, that's a reliable scientific, this one's for Antifa Joe out there who seems to be an expert and says nobody else is. But in 2021, they did a study that specifically analyzed 22 relevant studies and found that 16 of them focused on the single supervised injection facility in Vancouver, Canada, the first in North America. So safe to say most of the science around this that says these things work centered around Vancouver in British Columbia, right? Mm-hmm. Is that the study that you're kind of familiar with?
No, okay. So I looked at the ones that were in overseas, and that's the problem with how are they going to work in America.
Okay.
So that's
so you looked at overseas ones. Okay. Which, yeah, there's some Central European countries there that do this.
Yeah.
Okay. But so remember that Vancouver opened there first in 2003, and then there are, there are currently 51 of them. They've also decriminalized shooting up in Vancouver. They did that as of 2023. Since that time, the number of overdose deaths in Vancouver has more than quadrupled since 2014. So in 2014, 369 people died in British Columbia. Now, this is all of British Columbia, not just Vancouver, but 369 people died of illicit drug overdose. In 2017, that number almost quadrupled to 1,208 people. In 2023, there were at least 2,511 overdose deaths in British Columbia. So they opened the first OPC, SIS, whatever we want to call them, in 2003. And man, is British Columbia really tackling this with effective, scientifically proven data. And since 2014 to 2023, they went from 369 overdose deaths, illegal drug overdose deaths, to 2,511.
Right. They only work temporary when they first open. Okay. That's all they do. They work when they first open.
So they don't work. In terms of the long-term issue of solving addiction, getting people into recovery, and then, kind of reducing the number of overdose deaths, they don't seem to work, Lisa.
Well, no, I'm saying the study I read, they only worked when it first opened.
So why is this even a discussion? It's failed. We can look at Mass and Cass, and while not technically an OPC or SIS, it was an open air version of it where professionals went in there offering these same addiction services and drug testing and whatnot. And even Michelle Wu, who's as far opposite politically as I am, is now changing her tune and saying, we got to try something different.
Well, Mass and Cass, they've only moved around, and most of the state's money has gone to Boston.
And the money has gone towards these type of services that these OPCs would offer, correct?
I don't know what Boston has offered towards Mass and Cass, because I know that they've just moved it. But a lot of the state's money has gone to Boston.
Okay. So when people...
So Boston is just allowing, or they
They tried to fight it, but there were some organizations that went in there trying to do the same thing, but they didn't qualify it as an OPC. One of the problems is it's against federal law, and the United States Attorney for Massachusetts has said, no, this is not going to fly federally.
And I don't know how close Boston's syringe service programs are to Mass and Cass.
Okay.
So I haven't looked how close their syringe service programs are.
I do believe people were going there into the encampments themselves. Well-intentioned people, some of them, trying to save lives. I get it. But
and they also might just be going in and handing out needles too.
Correct. Yes, and that is part of what they're doing there. Right. But is it safe to say that people like me who say these things don't work, we're not idiots? We're actually basing it on data that's real world data out there, data that you've kind of shown as well. Long term, they don't work.
Well, possibly, right. And it all depends on how things are set up and what the parameters are around them and what the state puts in it. And that's what I'm saying. How is the law going to be written, and what are the parameters around it, and what's going to happen around it? And we don't know that. And
how can the law be written in a way that you think would work? I mean,
I haven't done that much research into it, so.
Because BC did, you said having private entities do it seems to have failed, right, in Rhode Island and New York, or in New York, I apologize.
So New York, when you look at the times that they're open, they're really only open 2 hours here and there. So how can that possibly work? And they're open sporadically here and there. So how does that really work? I don't know.
So there are some mitigating factors.
Right. The one in Rhode Island, it's only been open for 9 months, so I haven't seen any data around it.
Not enough time yet to see. Okay, fair enough.
I haven't seen anything around it. So.
But from the studies or the part of the world, Vancouver, British Columbia, which many people cite, and whenever somebody would disagree with me on social media, they'd send me a link to studies in Vancouver.
It seems like they're still dumping more money into it.
They're trying like heck. Dumping's a great word. It's not their money though, is it? It's somebody else's money, right?
There's a lot of money going into it.
If Bill Gates wants to dump his own money, or Elon Musk wants to dump his own money into it, but God bless them. I'm all for that. When you're dumping taxpayer monies, now we got a problem.
There's a lot of money going into it. I feel like whatever's been happening for the last 4 years in the city of Lowell with the co-op seems to be working a little bit better.
Thank you. And that's my point. Why aren't we using Lowell, your efforts, the co-op's efforts, as the model? Why can't Lowell's elected politicians, both locally and on Beacon Hill, say, hey, this is the model to follow, not Vancouver, British Columbia, which is an abject disaster.
Yes, and I can tell you that in January of 2023, we had 301 homeless people. And in July of this year, we had 215. So I just say that, like, we're doing something right.
And again, you get cyclical things. It goes up, it goes down, whatever. But so you talk about what your co-op team does and what these OPCs intend to do is get people ultimately, you can come in, you can use, we'll make sure you don't die, and then we're gonna try to get you into recovery, into whatever type of services. When you go out on the streets, how successful are you in getting people into recovery?
So it depends on the month, and it depends on how motivated the people are, and it depends on what's going on. So I can tell you, for some reason in July, it was one of the hottest months and people like to be outside, they got 22 people into treatment. Not quite sure why. Usually average of a month, it's usually between 10 and 14 people. So it really kind of depends.
When they're getting into treatment, is there any data tracking? Are they staying in it for 3 months, 6 months? Are they getting serious about recovery and doing the long-term work necessary? Or do you get them into treatment and then 4 days later, when the addiction starts clawing at you again, and you don't have the strength to fight it off, you're not far enough into your recovery, you're back out on the streets, South Common, wherever.
They do have some of that, but then they do have a lot of clients that will come back and be like, "Oh, is Joe here? I wanted to let him know, he hasn't seen me for the last 2 years. I have, I've been housed." He just, one of them just went to a wedding to be a best man at someone's wedding in Florida. They have a lot of people, a couple of clients just got their kids back. So they do have a lot of people that they've gotten into housing, into, places. They have 2 people who are in 6-month recovery programs. So they have a lot of great stories.
So there's some level of a success rate. By the way, for those out there who are thinking, "Oh, that's just a couple of people, that's several." In addiction, especially when you're talking opioid addiction with co-occurring issues such as mental health, which almost goes hand in hand with a lot of this, the success rate is brutal. If you're thinking about 100% success, you have to take incremental victories. So what you're doing seems to be working.
Yes.
Okay.
Yes.
In Boston, Mayor Michelle Wu mentioned is thinking of changing her tune. And I don't know if she's unveiled a specific proposal yet, but one of the things they're looking at is something to deal with addiction, but also with homelessness, is something called Section 35. Yep. Section 35 is?
Civil commitment. Yes. Doesn't really work, because what you're doing is you're putting someone in an orange jumpsuit and putting them in jail. We do have a police officer on the co-op, and if a family can do a Section 35 on a family member, you go to the court, you ask the court, the psychologist at the court for Section 35. They don't do it a lot, but you can get a Section 35. But it puts someone in jail up to 90 days.
So it is so when you commit somebody under Section, they're literally going into a prison. The RICA, whatever, I forget which jails are open and which are closed now.
Very costly.
Are they, when they're put into that prison, are they put into the general population with the armed robbers,
Yep.
murderers, rapists, whatever? Or are they put into a separate wing that deals specifically with addiction? Because Middlesex County Sheriff Peter 𝐶𝐞𝐬𝐚 used to brag to me that he has the largest addiction treatment facility in the county, Middlesex County, over there at the jail. So he's got some level of services there. I also know that post-COVID and post the social justice battle of 2020, we started letting a lot of people out of prisons for crimes that we no longer deemed serious. So there is space to make a giant recovery facility in some of our prisons, correct?
Right. I mean, I think that if there was room there, they probably would go there. But generally, a person's not going to stay for 90 days. It depends on how long they're going to stay for.
You can commit them for 90 days,
you
right?
can commit
Through
up to
Section
90 days,
35.
correct.
Is there a success rate there? Do we find that those are better able to get into long-term recovery if they've at least done the 90-day commitment as opposed to 3-day detox, 5-day detox, whatever these numbers are?
No, it's a very poor recovery, and when they get out,
Worse than...
there's a higher risk of overdosing and dying because they have no...
They've lost their tolerance.
Right. They've lost their tolerance, and they've had no therapy when they're in there. Yeah, you can detox them, so they give them the medications to detox them, but they've had no therapy when they're in there. And group therapy and spiritual therapy or whatever kind of therapy they need, they did not get. You have detoxed them, and that's great, but then they come out, and you have not fixed the trauma that they have. And then you put them back on the street. They have no place to live. They've lost their job. They have no insurance. They've lost their family. Now the stigma, and they've been placed back, and now they have nothing.
So why aren't we advocating for a Section 35A, which says you're going to be in there for 6 months, maybe longer if necessary, but as part of that, you will receive not just addiction counseling, you will receive mental health counseling if you need it. You will receive education if you need it. You will receive job training if you need it. So this is what the folks at the Megan House organization do. 6 to 12 months, sometimes it goes even longer, but they don't just treat the addiction, they treat all of it. There's family counseling, there's one-on-one counseling, there's group counseling, mental health, all of it is in there. There's an educational component, there's a job skills training component. It's a comprehensive model. Why can't the politicians just throw the resources into that for a couple of years and see if it works? But I will note that there has to be some kind of a mandatory component to it, because if you're free to go as you please, it's difficult to get into that long-term recovery. And I will state that many of the folks who end up in these 6 to 1 month treatment programs, they face the prospect of jail, especially for women. It was you're going to Framingham, or you're going to find yourself a long-term home, a real long-term home, not a 30-day whatever, or detox. And that was how a lot of people got into it. They didn't want to go. They'll admit that they didn't want to go, but they did it just to stay out of the prison population. And for many, it took, and it worked. And it's a constant battle, but it worked. Why aren't we doing it? Why aren't our politicians and our political leaders looking at that as opposed to all these other side things which just don't seem to work?
Well, I think it's a cost factor as well. And right now, if you look at everything related to HHS, all of our grants and everything really have been cut in half. So most of my grants have been cut by 50%. Most of my federal grants are probably going to be cut by the end of this year. So Health and Human Services is not where the money is being put at this point in time.
Okay. Where does your money go to in health? And when you get these grants, what do the grants go towards?
So we do have a prevention grant, but the prevention grant got cut in half. And then we do have a federal grant right now. So this will be the last year of the federal grant. I don't think it'll be renewed for next year because it is for like part of the co-op, but I doubt it'll be renewed. But just Health and Human Services as a whole, like CDC, like the webpage has been wiped out, NIH, things have been wiped out. It's just not something that's up and coming. BSAS is afraid, so the Bureau of Substance Addiction Services, like they're afraid some of their monies could be wiped out. Lowell Community Health has lost a lot of funding. Like just things that are related to Health and Human Services is losing money.
But do we know if things that are related to addiction and recovery services is being eliminated, or are they looking at other things that are not politically popular with the current administration in DC, so they're slashing away those, and it affects the overall numbers.
Well, they haven't been slashed yet, but we're just afraid it might be something that's coming up next.
Okay.
Yeah.
So again, maybe if our politicians would focus on addiction and recovery service as opposed to some of the other things that I won't get into for a different podcast, maybe the money
and mental health is not one of the things that's being funded that much as of right now. So yeah, that's not.
It needs to be.
Correct.
Mental health and addiction go, what would say, hand in hand, 90% of the time, if not more?
Yes.
Okay. So your civil commitment as it currently exists under this so-called Section 35, you're not in favor of, and you say it does not work.
No. And the thing is, addiction is like, so one person who explained it to me was, the first time they took a half of a Percocet, cut in half, they took it and it was like a switch went off and it was like, this is the best feeling in the world. And then they continued to take things and it was just the best feeling. And when you try to come off of something, it's like the worst case of a flu and you just, the feeling coming off is just terrible. And then you start to hurt and you start to have pain, and it's just coming out of that and seeing someone as they're withdrawing and going into some of these treatment centers that they don't medicate people well. You see people like when they say there's a bed available here, there's a bed available here, and they're like, they do not medicate me well, I cannot go there. And sometimes there are beds available, but the places there's beds available, they're like, they don't give me the meds on time. I can't go there. They don't treat me well. They can't. And that's part of the problem when people have beds available. They're like, I can't go there because the medications aren't enough to keep me from coming out of the addiction.
And we're talking about Suboxone and others.
Like they give different medications along with those things. Yes.
To help through the withdrawal. And the big challenge is once you've gone clean for a certain period of time, 90 days, you go out, and you decide you're gonna relapse, you end up using the same quantity you used beforehand, but your body does not have that tolerance anymore, and that's how we see a lot of these overdoses.
And then it's a fatal overdose, and they die.
Okay, how much of our homeless problem in Lowell, the homeless crisis, is due to addiction?
So it's really hard to tell. Sometimes the drug issue leads to homelessness, but lately we've had a population of seniors that are becoming homeless. So some people that their Social Security check isn't covering their rent because rent has become too high. So we're seeing a lot of different layers of homelessness right now. And we just recently had a call from an 18-year-old who ended up being homeless because, people, different cultures feel that, when their kids graduate high school, they shouldn't.
You're out. Yep.
Yeah, they're out. So we're seeing different layers of homelessness right now. So
and also the family structure isn't stable enough. So as soon as a teenager can get out, they get out, and that often leads to couch surfing and eventually homelessness as well.
Right.
How would you say the mental health treatment in the city is, at least the facilities that you have that the city can offer, that private organizations can offer, but also the state assistance you're getting?
Correct. So VinFin is our provider. So VinFin has like the grant. So they made these like different hubs. So VinFin has the hub for the for our area, and now they have the mobile crisis unit like within the area, which is fabulous because we can deal with them. And now we have the new restoration center opening in Drumhill, which is going to be great because we'll be able to have people who have substance use issues go to the restoration center as well. So hopefully that will take some of the heat off of the hospital, that people who are homeless, who have mental health issues, will be able to go to the restoration center versus going to the hospitals. And then the mobile crisis unit won't have to be dealing with all of the issues they're doing, and maybe we can weed out some of that.
But your data is showing that both on the homeless issue, Lowell is making some progress, incremental, not fast enough for everyone's liking, but there's progress, right?
Right. There is some progress, right? And Next week, the 17th, I believe, the Lowell Transitional Living Center will open for winter protocol. So during the summertime, they're open to, I think it's 120 beds. 90 beds, and then they open to 130 beds for the winter. So they do open up a little bit because we do hear that, they're full. They can't take any more people. There's nowhere for people to go. So they do bump a little bit more for the winter to take more people during the winter.
There's talk about potentially a new location. Folks have politically been trying to do that, get it out of the downtown, but also a newer, larger facility that can help more.
Correct.
If you create a larger facility, are you going to basically end the homeless problem by getting the people who are living on the streets into some type of shelter, or are you basically going to be a magnet to bring more in, and the problem will just get a little bit bigger? You'll just have more people in it, but the same number of people out on the street, out in the parks.
So we're still going to have people outside because some people don't want to follow the rules. So there'll still be people outside because people, when you go into the shelter, you have to give your belongings away. So you have to put your belongings into a closet, and people don't want to do that because they're afraid they're not going to get their stuff back. So, and your stuff is searched. So if you have drugs in your bag, the drugs are going to be taken out and thrown away. So people don't like that. So people want to be outside versus being inside. Also, like, people like to have a weapon or something on them, and they're going to be scanned. And if you have a weapon, your weapon's going to be taken away. So, I mean, if you're on the street during the day, you want to have a weapon or something like that. So people don't like to follow the rules, so they're not going to want to go in.
So you're saying there is, at some level, this problem will never go away. It will never be eradicated because just some people, for whatever reason, either can't help themselves or don't want to because it means giving up something that they
Correct.
don't want to
it's
give
just
up.
like a red light. So people are always going to go through a red light, or they just can't. They just can't.
Not once they put those damn cameras on there, then even I'll stop. All right. Okay, a lot of good information there, and I'm glad that we also got out the fact that Lowell is making significant progress and has. I remember when Councilor Cory Belanger was co-chairing one of the task forces. He mentioned to me he went to some kind of a seminar in Pennsylvania, and they highlighted all these steps that municipalities should take, and he said, Jesus, we're doing all of them.
Yes.
We're already doing all of them.
I go to conferences to learn new things, and I sit there. I went to a conference last week, and I'm like, I didn't really take anything back.
So, maybe you can hold the conference here in Lowell one of these years. So what's your message to those out there that are highly critical? There's a bunch of people, a lot of so-called experts out there who are critical about the city's handling, your handling, everybody combined. But usually the heat is on the politicians. They avoid you. But when they're dumping on how the city is choosing to handle these, they're in essence dumping on the work that you're doing every single day.
That's okay. They can dump on me, and they can push back at me. Just give me a call. I'll give you the facts. And there's web pages, and I mean, we have a Lowell Sun reporter that gives our data all the time. The Board of Health meetings are recorded, so people can watch the Board of Health meetings on the LTC. So they can watch it. They can also look at the Board of Health agendas on the agenda tracker. So the all of the statistics from Pride Star are there. They probably will need just a little bit of information on how to read it so that they get the right numbers on it. But the numbers there, we're transparent. The numbers are there. If anybody wants to know how to read them, they can call me. There is a BSAS dashboard, so the Bureau of Substance Abuse dashboard's there, so you can see how Lowell compares to the other cities, so you can see what our overdose numbers are. You don't have to question it. But I do look when people say things, I do look and I'm like, I wonder why they're saying that. And I'm like, wait a minute. No, you're the expert. You know what that is. What's the matter with you?
Everybody's an expert on social media. Yours truly included. Couple of other things I want to touch on with you. We mentioned kratom, rodenticides,
yes.
The Lowell City Council, and through, I think you guys kind of got the ball rolling on this a little bit through some complaints.
Yes.
Basically have banned the sale of kratom.
Yes.
In our communities. What is kratom?
Right. So kratom is like an opioid. It affects your brain like opioids do. And what happens is it actually came from Megan's house. So there was an over 21 tobacco store that was flashing kratom.
At the bus stop.
At the bus stop. And they actually sent me a message and said, like, this is terrible. Why is this here? And I got a couple other complaints. And I knew what kratom was from the hospital because somebody had somebody had it in their pocketbook, and I'm like, what is this? And she happened to be an overdose, and I'm like, what is this? So I had actually looked it up, and you can buy it on Amazon. And they were concerned because the girls in the house have to be clean, and you can't test for it. So I said to her, come talk to the Board of Health, and the Board of Health was concerned about it. And then at the same time, actually, the council had bought it up as well. So it was going on at the same two places. So it came up at both of them to talk about banning it. So we got a whole bunch of information, and then it went forward, because what happens is it works like an opioid, and it makes you high like an opioid, but you can't test for it.
So it's not technically an opioid, but it works like an opioid.
Works like an opioid.
Okay.
But you can't test for it, and in high amounts, it will becomes as an overdose, and it will kill you.
Okay.
But there are these people out there. This guy is called the Kratom Man or something, and he actually has web podcasts on Wednesdays, and he'll tell you how much you should take to cure your seizures and to help you with your pain and other things like that, which is not good. And but people will die from it. So the city of Lowell ended up banning it, and it actually became a chain reaction, because Drake had banned it, Chelmsford's banned it, Billerica's banned it, and now there's a House bill to ban it. But it's actually a supplement, and it's not FDA approved.
Okay. I've got so I'll play devil's advocate for a minute. I have a friend who actually used it.
Yes.
Very upset that Lowell banned it, and the discussion started. Believe there was some level of pain, but also to help someone sleep. If used properly in small quantities and doses of which it's intended to, it can be safe, was the argument. And why are we banning something that helps people and can help people with certain issues, because others are improperly using it?
And that's correct. And it's my understanding, and I don't know which way it is, it's like, so in Southeast Asian countries, I guess if you take it off, it's a plant. If you take it off of the root and use it as the root or something like that and chew it, it's actually safer in that versus how we take it and put it into production and make it into like powder or whatever. It's more potent like that. And also what they do is they're making it into like an energy drink or something. And if you drink the energy drink or 2 energy drinks or something like that, then that's when it becomes more powerful. So if the FDA just tested it and said like this much is like okay for you, then that would be better.
Okay. Rodenticides.
Yes.
These are basically poisons to kill rats.
Second generation
mice,
anticoagulants. So like when people take Coumadin or something to thin your blood, like if you have a cardiac issue like that, that's what it is. It's like a Coumadin or something
that's
like that.
That's what a rodenticide
or
is?
heparin or something like that. Yeah, it's a second generation anticoagulant.
All right. And what's it generally used for?
So it's used as in rat poison. It's a rat poison. So it's used in a box. And it basically is a poison, and it basically is an anticoagulant to kill the rats.
Is it effective?
Oh yeah, it
kills rats.
Kills rats.
Right.
But then any like a dog or a coyote or anything else that comes and eats the rat. So basically hawks, yeah, whatever. But what will happen is it doesn't kill the bigger animals, and what will happen is they'll get sick, and it will thin their blood. And then the bigger animals won't die, but they'll end up having their blood will just be so thin.
Is this a major issue? Is it happening so often that it's worth it to run the risk of not banning a safe and effective rat poison? Rats, I've heard the horror stories of the Black Plague and medieval times, and what too many rats can do from a public health perspective. So
one hawk, I believe, can eat like, I thought it was, and I don't have the number, like 200 rats. Or mice and rats. So you're better off keeping the hawks and the regular wildlife and the coyotes and things to eat. You know how it is, hierarchy, just eat the things. Versus putting...
Mother Nature usually solves its own problems if we humans would leave it alone.
Rather than putting the rat poisons out there. The other thing is that, like, if we controlled, like, the dumpsters and things like that and kept the lids on the dumpsters and stuff like that downtown versus leaving garbage out and around so that we don't have the rats out here.
Are you monitoring rat situations now? Is this going to be something that you're going to monitor to see if we're starting to see an uptick in that issue because of the banning of rodenticides?
Yes, and actually we do have an IPM for the schools, and we have not used the second generation anticoagulants in the schools for over a year. And this was the first year that none of the schools were on the failed inspection report. Oh. So it has worked in the schools. Okay.
What is that for people who might want to buy it for their homes commercially? What type of product should they be looking for?
That's a great question, but I'm not really sure.
All right.
But Banner Pest Control is the one that is in the schools, and Modern was the one for. But any pest control company, just let them know that you don't want the second generation anticoagulants.
All right. Awesome. I've kept you really long, and I have to go as well. But there was a political hubbub about the reduction in the last city budget.
Yes.
The second most contentious thing, other than the supposed reduction in the school department staffing, excuse me, there's that little tickle, was we were down to one public health nurse, maybe two instead of 3 or 4. Where do you have enough public health nurses on your staff to keep the city safe and healthy?
So everybody lost some positions or open positions. We did not lay off anybody within the health department. But what happens is we're given like a budget for the health department. So what ended up happening was we had some resignations, retirements. So we were down to 1 public health nurse. So when I had a retirement, I reallocated funds. So now we have 2 public health nurses. So we can do that within our checkbook.
You have 2 public health nurses. What's the ideal number for a city of 120,000 people?
It depends on how many cases we have and what we have going on. So we can work with the 2 public health nurses and a public health nurse manager. I'm also a nurse, so I can step in as well. So that helps with what we're doing.
Okay. So it was not harmful to the city's overall public health and your ability to do what you need to do as far as you can.
So right now we're going into flu season, so this is when we're busy. So it's helpful that we were able to fix what we were doing going into flu season. So this is the time we need it.
All right. So whatever cuts were made, you've been able to find the money. Yes. You're a good budget manager.
Yes. Yeah. I've managed my own budget for my own finances for years, so we could do this.
Right. Can we send you over to the schools?
Sorry. No, thank you.
I'm not going to drag you into that one. Okay. Flu season. You mentioned it.
Flu season. Yes.
What are we always get a prediction. This is going to be a bad flu season. This is going to be a horrible flu season. What's the prediction for 2025, 2026?
So last year was a bad flu season. There were quite a few hospitalizations. They predict this year will be about the same. But last year we had some vaccine hesitancy, and we all know why. Yep. We're hoping this year some other people will get their flu shots because they were sick last year. I believe last year there were, I think it was 250 pediatric deaths in the United States. I believe there were 12 pediatric deaths in the state of Massachusetts, which is a little concerning. So this is the time to get your flu shot if you are someone who gets a flu shot. I believe the health...
Who's it recommended for?
So anybody who has any health issues should get a flu shot. Any children with like any health issues should get flu shots. Anybody, elderly should get a flu shot. Anybody who lives in a nursing home or something like that should get a flu shot. Obviously, healthcare workers are supposed to get flu shots because they work with or in a doctor's office because you work with people who are sick. But 2 weeks, we're 2 weeks out from Thanksgiving, so if you're going to be around your elderly to protect them, you should get flu shots. But I believe we've given out like 250 flu shots already just from the health department. But
you give them out at the health department?
We do, right across the street. And we've done homebound people. Anybody who's homebound who wants a flu shot can call the health department. Nope, we're free.
Okay.
Yep, we're free. All and, right. CVS and Walgreens are giving out flu shots. But your best prevention is hand washing. And people love to just wash their hands like this. 20 seconds, sing happy birthday twice.
My daughter does that. Okay. You mentioned hesitancy.
Yes.
Goes back to the COVID crisis. There was some talk, I don't know if it was legitimate talk or scare tactics that the COVID vaccine was going to be rolled into the flu vaccine.
Yes.
Does the flu vaccine contain any components that were used in the COVID vaccine?
Not that I know of. So I believe not, because there is a second shot, which is a COVID shot, if people want to get a COVID shot.
Those are still available.
Shot. Yes,
okay.
there's a COVID shot.
Is it a bad COVID season? Is at this point we don't hear COVID so much, but we do hear about flu. Does that mean that we're not worried so much about COVID anymore, or
COVID
has it rolled into the flu?
COVID still exists, so people are still being tested for COVID and flu if they come up with a respiratory. But we've lumped it together as respiratory season. So if you're sick with respiratory symptoms, you should stay home if you have a cough or cold until you are 24 hours fever free. So if
that's been the advice forever, right?
Yes,
my wife is a nurse, so
exactly.
I deal with this with my kids.
Yes, and that's what we tell you. If you go home with a fever, you should stay home until you're fever free without fever reducing medications.
And that includes if you test positive for COVID, or do you still want people who test positive for COVID to lock themselves up for 5 days?
No, you don't have to lock. You don't have to lock yourselves up.
24 hours fever free. Same guy.
24 hours fever free, or until your symptoms are better. So yes, so don't go to work coughing on your friends, and it's not appropriate to have your tissues all over your desk anymore.
I still see people wearing masks.
Yes, people are wearing masks.
Are they effective in preventing the spread of respiratory virus?
Well, I
if we had this discussion 5 years ago, we'd have been taken off the air.
Yeah, I think that people are wearing masks to protect themselves because maybe they're immunocompromised or undergoing cancer treatment.
Does it work for immunocompromised people?
I'm not quite sure. I kind of want to ask them in the supermarket, but they might hit me. But I think if they're undergoing cancer treatment, I think maybe that's why they're wearing them.
It makes sense in that case. But has science determined whether it's more harmful or helpful? Because I know there was a time where even the famous Dr. Anthony Fauci said, "Don't do it; it's worse." But then suddenly he changed his tunes, and if you said it's making it worse, you suddenly were ostracized.
Well, I'm sure it can't hurt, right? I'm sure it can't hurt.
Does it keep some of the contaminated particles in close proximity to your mouth and nose?
Well, the thing is, like, if you...
I'm getting a YouTube warning label on this, by the way.
If you put a dirty mask on, it's not going to help anyway. And then if you don't wash your hands and you take your mask off and you put your hands in your mouth, it's not going to help anyway.
Which we were all doing.
So it all depends on your hygiene, what you're doing, right?
So the advice for those who are going to use masks is bring like a dozen of them with you when you go out to the store, so that every time you touch it, you can change it.
And wash your hands.
And washing your hands, amazing, a simple little things. Vitamin D, another little thing. Go out, if it's a sunny day, go outside.
Right, go outside or take vitamin D.
My doctor put me on that 20 years ago, by the way. He was ahead of his time.
Yeah, because the sun, the ozone layer is blocking the sun. So you're not going to get the vitamin D anyway.
All right.
Because of the ozone layer.
All right.
But that's another podcast.
That's for the next podcast. Anything else you want to add?
No, I think
have I gotten you in enough trouble?
No, I'm not in trouble.
Okay. All right. Lisa Golden, the Director of Health and Human Services for the City of Lowell. Thank you. It actually was, all my kidding aside, I think it was an informative discussion, and I hope people pay attention to it, because I think there's a lot to be learned there.
Yes, I think so.
All right. You have an open invitation to come back at any point.
Thank you.
Thank you. Thank you to Lisa Golden, and thank you for tuning in as well to this edition of the Daily Pulse. Hey, tomorrow, special time for the Daily Pulse Live. We usually do it at 10 o'clock. We're actually going to do it at 11:30 tomorrow to accommodate a couple of schedules, but also to deliver a major announcement in the city of Lowell. Something about a building. I'm going to leave it as a tease as that. Till then, everybody, please stay safe. Please stay warm, stay healthy, wash your hands for 2 freaking minutes, sing happy birthday twice, and we will see you on the other side.